So I really want to thank you all for joining us today. We're getting back to kicking off our masterclass on EP and device, and I don't think we could find a better person to kick it off than Dr. David Singh from the Scheinman Foundation. He also works at Heart Rhythm Specialists in Dallas, Texas, and we'll be doing a talk here on arrhythmia basics with a little bit of fun and interaction. So, David, if you want to go ahead and kick it off here, and then for everyone else here, just ring out in the chat when you have any questions or would like to participate.
Thanks, AJ. I'm feeling a little under the weather, so I'm going to spare you the horror of my face today, and I'm a little short of breath. I'm not being lewd. I'm just having a little bit of an upper respiratory thing going on. I've been doing this kind of Jeopardy thing for several years, and I found it's a kind of a fun way to just introduce key arrhythmia topics. I think for this, probably the easiest way is to interact during the chat. I definitely want it to be interactive. So what I'm going to ask is, for example, if AJ leads it off, he might choose impulse control for 100. I'm going to show a question. And then if you could just put in the chat what you think it is, that would be great. And if the correct answer shows up, I'll explain it. If not, we'll go through it. I've tried to calibrate this to multiple levels. I apologize in advance if some of it is harder than others, and some of the lower number dollar amounts are supposed to be a little bit easier. But don't worry if you don't understand these concepts, because hopefully you'll be hearing them over and over again over the course of this curriculum. All right, AJ, why don't you start it off verbally, just so we can get going.
Okay, perfect. How about we go with why am I so fast for 300 dead middle?
Oh, wow. Okay. If you're allowed to order one lab test for the patient with the telemetry findings seen below, it would be what? And just put your answer in the chat if you think you know what it is. That's right. So Abel got the right answer here. So this is hyperkalemia. And, whenever you have like a really bizarre QRS that just doesn't quite make sense, it's bizarre, it's wide, you may or may not see P waves, you always have to think about hyperkalemia. So this patient had a potassium of 9.9, and this is very typical of what you might see. You keep in mind, this may not be a ventricular rhythm. This still may be supraventricular. It's just that because the potassium is so high, depolarization down the ventricle is very slow, leading to widening of the QRS. So you don't necessarily call this VT, although VT is possible. Typically, with really high levels of potassium, you get asystole, right? That's what they use in prisons when they're trying to kill people. Sorry for the macabre reference, but hyperkalemia at really high doses will result in asystole. Okay, who wants to take us to the next question? You can just put it in the chat. If not, I'll just keep picking on AJ.
Well, I was going to give Abel the shot since he got the last one.
Yeah, that's technically how it should work. So Abel, if you want to take us to the next question, that'd be cool.
I'll give him about 5 more seconds here. Okay. What? Oh, please don't die for 400.
Okay. Please don't die for 400. What drug was infused that would account for the difference in these two EKGs? So this is pre-infusion, this is post-infusion, and I could accept a couple different answers here.
And the chat is open for your suggestion.
Yeah, Agenoline, good. And do you know what condition this is? Yeah, Brugada. So if you look here, you can see there's sort of this coving in V1, which is suggestive of a Brugada pattern. It doesn't really look like a typical right bundle. And there's a lot of debate about, type 1, type 2 pattern. But one thing that we do sometimes, if we are unclear about whether it really is Brugada or not, is we can give a sodium channel blocker, right? And so in general, not all genetic mutations, but most of the time, the genetic mutations associated with Brugada pattern are due to abnormalities in sodium channel coding, right? SCN5A is a very common one. So if you give a sodium channel blocker, you'll accentuate that pattern and bring it out. This was an asymptomatic young kid that I saw. I think he was 18 when I saw him, and I, was kind of unclear about whether it was Brugada or not. And so I did a procainamide challenge on him, and it was, quote unquote positive. How to manage these patients becomes a little more complicated, but we actually just watched him because he didn't have any high risk features. Okay, this was procainamide, but you could use asmoline or flecainide if you needed to. Oops. Okay.
Everyone just ignore that. Fantastic. So, Fifi, you got the last one right. Do you want to lead us off?
Device details.
Device details 300.
The syndrome responsible for the following, not tracing, sorry, chest x-ray.
We got Twiddler from a bell. Quick hands
this is Twiddler. Yeah. So I don't know if you've had a patient like this. I've had a few over my career, but whenever you see a patient that's done this, it means they're fidgety and they've wrapped the device, sort of, just rotated it over and over again. And what you'll see is coiling of the lead. Sometimes it'll actually get dislodged. So, this is a serious sort of discussion with the patient, like, are they going to be able to not twiddle in the future? Are they dependent? Do they really need it? I don't really recall the details of this one, but this was sort of a classic Twiddler. Okay, nice. Where are we going next? Whoever got
the
that
board
one
is
right.
yours.
Yeah. Device 400. I guess if it's easier, you can try just talking to, because it looks like there's a delay. That's fine with me. You can try that out next time. All right, device details 400. What is the most likely etiology for this dual chamber pacemaker tracing?
Anybody in the chat have a guess?
Or any brave souls want to comment? Okay, so let's think about this for a second. Whenever I'm analyzing pacemaker tracing, I want to ask myself a few questions. One, can I infer whether this is a dual chamber device or a single chamber device based on this EKG? And the answer is, I think you can. If you notice here, this is ascens v pace, ascens v pace, ascens v pace.
We do have a guess of PMT from the chat, just so you know.
Yeah, sorry. Yeah. So when you look at the left side of the tracing, what you see is the pacemaker is pacing the ventricle quite rapidly. And there's really only a couple reasons why a pacemaker would pace at this fast rate. One, you could be tracking something in the atrium, right? So there could be an atrial arrhythmia going at 120 beats per minute or whatever it is, and the pacemaker is just doing what it should, right? It's just pacing in response to an atrial sensitive event. The other thing to consider, which was put in the chat, is PMT. So what is PMT? So PMT is if you have, often it's set up by a PVC, which I don't have here on this tracing, but it's often set up by PVC. And what happens is you get retrograde conduction to the A. So PVC retrograde conduction to the A, right? So you have a V pace or a V sense, an A sense, and then once you have an A sense, it's going to be V pace, A sense, V pace. So every complex that's paced is going to be the result of retrograde conduction. You're going to have retrograde conduction sensed by the A. This is also called endless loop tachycardia. And does anybody know how we can adjust for this if we observe it?
Someone says extend P-bar.
Yeah, extend P-bar. So basically what you can do is you can figure out where the device is seeing that atrially sensed event, and you can extend the post-ventricular atrial refractory period to blank it out. So even though it might see it, it doesn't act on it. And that will prevent the PMT. Now, this can get tricky if you have very long VA conduction times, but In general, that's our first move. Now, why did it break here? There are a couple different possibilities. You could have VA Wenckebach. Remember, Wenckebach can exist really anywhere in the heart. It can exist in the His-Purkinje system. It can exist in the AV node. It can exist in the sinus node. And it can exist in the retrograde conduction. So if you had VA Wenckebach and your VA timing kept getting longer and longer, eventually it would drop and that would break the PMT. Okay. I can't prove that here. Another possibility is these devices sometimes have algorithms that extend the PVARB automatically. So it's possible this device recognized this as possible PMD, extended the PVARB, and then it broke. And as you can see here, it went back in. This is very interesting because here you don't see a PVC, but it goes back into PMT. So does anyone know, this is sort of like bonus question, does anybody know, since this was not started by a PVC, what can we infer about the physiology of the AV node here? Any ideas? So my guess is since you're coming down the AV node here, and by definition, because this is PMT, you have to have retrograde conduction that sensed this patient has dual AV nodal physiology. So my guess is you're coming down the fast pathway here, up the slow pathway here, and that's why the PVARB is not adequate to have blanking. So you can learn a lot from this tracing and make certain inferences based on what we're seeing. Any questions about that?
No questions from the chat.
I don't know how to interpret silence, but
Fifi, you got the last one right. Why don't you go ahead and hop in there? The board is yours. Impulse for 400.
Impulse control 400. Carotid sinus massage was performed in this patient and the following EKG changes were observed. What is the name of this condition?
And we're just waiting for anyone in the chat to
So
shout out what they
I
think it might
think
be.
that's probably right. There may be some nomenclature differences here. I would call this not Bisol-Gerish. I would call this carotid sinus sensitivity. Okay. So in general, yeah, that's right. So in general, I mean, we have baroreceptors on our carotid, bulb, and it's not uncommon if you mash on the carotid, you can slow the sinus node and slow AV nodal conduction. Now, there are a subset of patients, when you do this to them, they faint. So whenever I'm working up a patient that's fainted, one of the things I'll always do is carotid sinus massage. And in this patient, when I mashed on his left carotid, nothing happened. When I mashed on his right carotid, he passed out, right? So now there are different reasons why this can happen. In this case, I think he just had hypersensitivity. There are people with low endogenous adenosine and kind of weird kind of stuff that sometimes accounts for it. But another thing to look out for is patients that have tumors in that area. I remember I had a really wild case as a resident where the patient had a neuroendocrine tumor invading the carotid bulb. And every time she brushed her teeth or turned her head to one side, she fainted. So the classic history here is, oh, I'm brushing my teeth and I've passed out. And in this case, the patient had pretty classic symptoms with carotid sinus massage. Okay.
Are we counting cardioinhibitory response as the answer, or?
I would say that is not how I would refer to it. When I think of a cardioinhibitory response, it's technically not incorrect, but I refer to cardioinhibitory response as one of the outcomes that can occur when you do tilt table tests. Okay. So in vasovagal syncope, which is similar, but it's not the same thing. These are, little old ladies that faint in church, people that get their blood drawn and faint. What happens is you get this huge vagal surge, and sometimes doing a tilt table test, you can evoke this or bring it out. My personal feeling is I don't think you need to do tilt tables. I think you can get it with history. But within vasovagal syncope, there are three types. There is cardioinhibitory response, which is characterized primarily by lowering of the heart rate. And those are patients that might actually respond to pacemakers, but that's the rare subset of patients. So we rarely put pacemakers in these patients. There's vasodepressor response, which is just an abrupt decrease in systemic vascular resistance, and the most common is mixed. Now, what normally happens is the SVR tanks first in the mixed subtype, and by the time the heart rate has slowed down, the patient is already fainted. So that's why for patients with mixed types, that is cardioinhibitory and vasodepressor, they tend not to respond well to pacemakers. There's some nuance around that, but I would keep that term for vasovagal syncope. I don't know if other people feel differently, but that's how I use it.
Okay, fantastic. So Yara, you were right on the line there as far as the answer, but we'll go ahead and give you that one. So the board is yours if you want to take the next question. And just to recap scores, we have Fifi at the top with 800, Abel with 600, Yara with 400.
Nice. Okay, we're keeping score. We got a little competition going. That's cool.
That doesn't mean that everyone else
but there are winners.
There are winners. So Yara, the board is yours. If not, I'm just going to choose one for you.
Where are we going next?
Let's do device details for 500.
Okay. What is the most likely explanation for this paced rhythm?
And the chat is open for your response. Looking like about 100 beats a minute, unless I'm reading that wrong.
Yeah, that's right.
Yeah.
And again, when you see a fast-paced rhythm, you have to ask why. It could just be tracking, right? So it looks like there are P waves here prior to. But what do you notice about this QRS? Does this look like a typical QRS for a paced rhythm?
It looks a little more narrow than I would expect.
More narrow, right. And is it a right bundle or a left bundle?
Anyone in the chat want to voice their opinion?
So this is left bundle pacing. This is referred to as conduction system pacing. And in the US, there's been a lot of interest in this, resurgence of interest, I should say. We started by trying to pace the His bundle. Now think about it. If you can plug your lead into the conduction system, that's going to give you the most normal wavefront of depolarization down the ventricles. We know from the David trial and from other trials that RV pacing is bad for patients, right? If you've ever been in the ICU and someone needs a temporary pacemaker and you start pacing their ventricle, their right ventricle, their hemodynamics will often tank. We know that a certain percentage of patients with a high burden of RV pacing will develop heart failure. So the idea would be if you can plug into the conduction system, you can attenuate the damage that RV pacing provides or creates. What we learned with His bundle pacing is that it's very painful. It's a very small target. The thresholds are variable. And some very enterprising folks decided, well, the left bundle is much more forgiving than the His bundle. It has what we refer to as arborization. So when you have the left bundle, it basically splits into left anterior fascicle, left posterior fascicle. And there are many, many branches of the left bundle. So if you take your lead and you put it in the RV septum and you keep turning, so you go through the septum, not all the way through, but into the region of the left bundle, what you will find is you get a very narrow QRS. And typically right bundles don't really have the same hemodynamic problems that left bundles do. So this is a really exciting development. We think it might be an alternative to biventricular pacing. It's certainly cheaper if it's done correctly. And so one of the clues is not always, but you'll often see a right bundle. This is a very narrow QRS. I mean, this is like 110 milliseconds, right? There's no way that you're pacing the RV with a QRS this narrow. So this is what we refer to as conduction system pacing. And in this particular case, this is left bundle area pacing. Any questions about that? Cool.
All right. So, ERA, the board is still yours. If not, I'm going to pick another one for you. Okay, why don't we do a random facts for 300?
300. You like the middle of the board, AJ. I like it.
I like the middle.
All right. This Houston-based EP signed up for a Cybertruck, but is not claiming it due to personal difference with Tesla's CEO.
Is there anyone on the panel that wants to voice?
Does anybody want to confess? Okay,
That
well,
was me.
I was asking for some random factoids today. I'm with you on that one, but I'll keep it apolitical, okay? All right. Where are we going next, AJ?
Oh, hold on, I gotta give myself points for that. No, wait, that was a Joma. Okay, let's do.
Joma got it right.
Yeah, Joma got that one. Please don't die for
I hope so.
300.
Which one?
Please don't die for 300.
Please don't die for 300. The name of the following arrhythmia.
Anyone in the chat have an opinion on this?
Yeah, Abel's right. This is Torsade. Now, I want to make a very important point here, guys. Anybody that's trained with me or has worked with me knows this is a pet peeve of mine. Okay, this is one pet peeve is that you don't pronounce the S, but that's minor. I can live with that if you say Torsades, although it's like fingernails on a chalkboard a little bit. But this is polymorphic VT. And a polymorphic VT is not always Torsade, but you can have polymorphic VT that will look very similar to this. Okay, now, why is this Torsade and not polymorphic VT? There are lots of different causes of polymorphic VT. You can have channelopathies. The most common is probably ischemia, right? And you'll have this twisting of the points that you see here. The reason why this is Torsade is that it's pause dependent. Okay, so you see whenever this is set up, it's set up by like a short, long, short sequence. The reason is that this is usually done in the setting of a long QT, okay? And the previous diastolic interval is responsible for repolarization of the next complex. So if you have a long diastolic interval here, this complex will take a longer time to repolarize. You get early after depolarizations. If they're above threshold, you're off to the races, okay? So a couple other things. So one, don't call it Torsade unless it's pause dependent. That's really key. And two, the treatment of this is very different than, let's say, polymorphic VT for some other reason, right? If this is due to long QT, if this is Torsade, what is the appropriate treatment for this?
We have Mag from the chat.
Yeah, MAG is good. You want to do that first. But the key is you want to pace the heart, okay? You do not give amiodarone. I used to go crazy. The nurses that worked with me were like, oh no, someone gave amiodarone for Torsade. Don't give amiodarone. You're just going to prolong the QT more. It doesn't help, right? If you're going to use any drug, you want to use lidocaine because that suppresses the ADs. But really, what you want to do, if you can, is increase the heart rate. The ideal situation would be to use a temporary pacer. If you don't have that available to you, you can use something like Isopril. Anything that will increase the heart rate will shorten the QT, okay? So this is Torsade, and I just want people to kind of emblaze that in their memory. It's always pause dependent, and it's usually seen in the setting of a long QT. Now, Torsade long QT can be due to acquired causes or inherited causes, right? So there are inherited channelopathies that patients are born with that result in a prolonged QT, and those patients will sometimes have sudden death, particularly if they go on a medication that further prolongs the QT. And then there are patients that are like admitted to the ICU, they get some antiemetic, they get some other stuff, and then the next thing you know is they're going into Torsade. There's one final point that I want to make about Torsade that is like, and then I'll get off my soapbox. If you see someone code from Torsade, I challenge you to do this. Go back on telemetry, okay? You will always see short bursts of Torsade beforehand. The first event is never a code, right? So what that means is you'll see short little, see this like you can see here, right? This self-aborts. Oftentimes Torsade will abort, right? So we have an obligation as physicians, nurses, providers. If we see this is not just run-of-the-mill non-sustained VT. This is a harbinger of something bad that's about to happen. And you can correct it, prevent the patient from being coded by intervening early by Isopril, pacing, lidocaine, MAG, all that kind of stuff. Any questions about that?
One thing I would add here too is, for the people coming to check a device with a patient who has had Torsade, say you go to the ICU and they're like, oh, I just want to make sure the device is okay because it gave some shocks. You might not want to test your ventricular thresholds because that threshold loss of capture could kick off Torsades in another round of shocks. So always be, conscious there when you're interrogating a device that you need to take account the patient situation as well. So, Abel, you got the last one. Do you want to pick the next question?
Please don't die 500. Beautiful. Okay, what is this?
It's nasty. Pretty excited AF.
Exactly. Perfect. Beautiful. I love it. This patient was started on amiodarone in the ER, which was the wrong thing to do. You might get confused between this and polymorphic VT, but honestly, you don't see twisting of the points. Okay. The key here is you have various widths of QRS complex, right? So some are wider than others. It's highly irregular. Okay. So if you consider AFib, just run-of-the-mill AFib, the atria are beating 400 to 500 beats per minute. Now, why don't patients with AFib die? If you pace the ventricle at 500 beats per minute, that's called VFib. Well, fortunately, teleologically, or whatever you believe in terms of how we were created, the AV node, it has some properties referred to as decremental properties. So the AV node will never allow that many impulses to get to the ventricle. It protects us. So if someone has AFib, they can have rapid ventricular rate, but they will never have a rate this fast. If you have an accessory pathway, and that accessory pathway is what we refer to as, robust enough, if it's able or capable of very rapid conduction, then you may get beats per minute of like 300, 250, 280. And that is a very dangerous situation because when you pace the ventricle this fast or the ventricle is being depolarized this fast, it can degenerate into VF. So this is why patients with Wolff-Parkinson-White die. The overall incidence of death in young people with WPW is about 0.1%, higher if they have high-risk features like syncope. But this is what I would consider to be a high-risk pathway because it's extremely rapid. And so this would be an indication for ideally ablation. Does anybody want to take a stab at localizing it?
Anyone in the chat?
So really simple rules, I think. Yeah,
right side.
Yeah, that's great, KT. So the thing is just very simple. You can memorize algorithms, but I like to think in terms of physiology. This is a left bundle with a later transition, like at V3, right? So if it's a left bundle, it's mimicking left bundle branch block. It's coming from the right side. Okay. Septal tends to transition at V2. Remember, V1 and V2, Dr. Scheinman taught us this, V1 and V2 split the septum. So if you're down in V1, negative, up in V2, that's more likely to be a septal pathway. So this is probably a right free wall pathway. In fact, that's what it turned out to be. How do you treat this? In the ER, acutely? Any ideas? Yeah. If you have procainamide, that's great. Obviously, if they're not stable, you shock them. If they are stable, you can use procainamide. The key is you want to use an agent that blocks both the pathway and the AV node. If you do something like a beta blocker, you could be in for...
Hello, Singh.
Yes. Go ahead. Did someone have a question?
Sorry, Gandhi. I think I just muted you on accident. There we go.
Hello.
Hi.
Yes, how are you?
Good. How are you?
I'm really good. Thank
Did
you
you
so
miss
much.
me?
Yeah, I'm following you very closely. May you go back on the localization of that pre-excited atrial fibrillation? Yeah. I think I just missed just a point when you are citing.
I think
referring to
yeah.
V1, V2.
No, it's good. If V1 is, if it's a left bundle and your transition is at V2, it's coming from the septum. Because the septum splits V1 and V2. If you think about the precordial leads, V1 is on one side of the septum, V2 is on the other. So you're going to be going away from V1 towards V2. So Scheinman taught us if your transition is at V2, it's a septal pathway. And in this case, if it was at V2, it would be anterseptal. This is a later transition, so it's more likely a right free wall pathway. Does that make sense?
Yeah. Thank you.
Sure. Any other questions on that? Okay, where are we going next?
Well, Fifi got the last one right, so it is yours. We'll give him about 10 seconds to guess. Impulse for 200.
What part of the conduction system is causing problems in this tracing? Where's the level of block, I guess I should say.
Anyone in the chat? About 5 more seconds here. So would this be, yep, exit block, perfect. Sinus.
Yeah, this is very good. So a lot of people might be tempted to call this AV nodal Wenckebach, but that is not the case. In AV nodal Wenckebach, there's nothing wrong with the sinus node. So you see P waves marching through. Okay, there's a block here, and there's no P wave. So just like I was saying earlier, you can Wenckebach in different areas of the heart. The AV node is what we learned about first in med school. You can Wenckebach in the sinus node. You can have Mobitz 2 in the sinus node. So this is a form of sinoatrial exit block. And the key here is you have a pause with no intervening P wave. So that's where the problem is. Make sense?
Fantastic. Fifi, the board is still yours. Recap on scores here. We have Fifi leading with 1,500, Abel right behind him with 900, but they've answered almost the same amount of questions. ERA behind that, and Ijoma with her answer there.
Okay, where are we going next? You got
Why
that one.
so fast for 400?
Why so fast 400? The most likely anatomic origin of the following Y complex tachycardia.
Any thoughts in the chat? Give you about 5 more seconds here. Basal septum. LVOT.
I would not say LVOT, but it's a good guess. So the first question is this supraventricular or ventricular? Things that you can look for are AV dissociation. And whereas you can't march the P waves necessarily, you know, if you look, there are small disturbances in the QRS at various points. And that to me suggests AV dissociation. So I would guess that this is VT. Now, keep in mind, the localization rules for VT are similar to WPW, right? So if this is a left bundle, if it were coming from the septum, it should be positive in V2. Your transition would be much earlier. Here, your transition isn't until V5, okay? So if you think about that, that's very much like a left bundle branch tachycardia coming from the ventricle. It's not coming from the septum. So most likely this is coming from the RVOT. LVOT, you would usually see your transition more at V3. RVOT can also transition. This is a very complex space. But in general, if you have a left bundle VT with a superior axis, an inferior axis, so up in 2, 3, and F, negative in V1 with a late transition, this is most likely RVOT. These are so-called idiopathic VTs. These are highly amenable to ablation. They'll sometimes respond to, even calcium channel blockers, and they're typically not dangerous. So I've seen a lot of patients get ICDs for this, unless they're fainting and having really concerning symptoms. In general, I try to avoid putting devices in them unless, I'm really concerned. Any questions on that? There's a very good paper from the UPenn group many, many years ago, Marshalinsky and colleagues that, you like sort of describe the EKG patterns for various outflow tract tachycardias. Remember, the outflow tract consists of a lot of stuff. It consists of the epicardial surface of the RVOT. If you go through the RVOT, you have the posterior surface of the RVOT. You have the septal side of the RVOT, the lateral side of the RVOT. If you kept walking through the posterior wall of the RVOT, you would hit the aortic cusps, right? So this region is really quite complex. And when we're ablating outflow tract VTs, we really have to try to localize exactly where it's coming from, because if you start burning in the wrong place, you're not going to get it. And oftentimes these EKG rules can be helpful. They're not always 100%, but they can be helpful. Okay. Next.
Fifi, the board is still yours. Impulse for 100.
Why is there a pause in this tracing?
Anyone in the chat? Any thoughts?
Yeah, I like it.
Interhisian
block, Mobitz 2
2
block. What you see here is PR, which is not terribly long. You don't see prolongation of the PR. Your sinus P waves are marching through. This drops, and then your return PR is the same. So this is Mobitz 2. It's most likely associated with infrahisian block. We get a little more excited about this because it's more likely to progress to complete heart block than AB nodal linky block. So if we see this, we want to be sure that we're doing the right thing for the patient. Good. Okay. Next.
EP, got that one right. If you want to pick the next question.
Random facts for 500. He's one of the only EPs in the region performing ablations and is headquartered in Dar es Salaam. Gandhi. Gandhi got his own question wrong. I had a chance to go visit him, and I know a lot of other people on this call are either have done trips to JKCI or planning them, so good stuff. Okay. Notice that he uses shoe covers for his headgear, which I brought back to my hospital on the mainland, and I don't know if it's quite a trend yet, but we're trying. Where do we go next?
Fifi, you got the last one right. If you want to pick the next. Please don't die for 200.
Please don't die 200. This EKG can be seen in an inherited channelopathy. What is it?
Long QT.
Okay. And is there a subtype that you want to get more specific about?
Type 3.
That's really good. Yeah. So there are many different types of long QTs due to an array of genetic mutations. In general, the ones that we kind of know about are long QT 1, 2, and 3. Long QT 3 has a very peculiar sort of pattern, which is in long QT 1, you see this big broad T wave. So the QT is being driven by a very long T wave. Long QT 2 tends to have a notched QRS. And then long QT 3, the predominant reason why the QT is long is because of the QRS to T interval. This is what's driving the QT. And these patients will often have Torsade response to emotional stress. I had a patient that had long QT 2, and the classic one here is the alarm clock. And she said whenever she was in school and the bell rang, sometimes she'd faint. So the alarm going off can trigger Torsade. Does anybody know what acquired form of long QT, electrolyte disturbance, mimics long QT 3?
Anyone in the chat? What electrolyte disturbance mimics long QT type 3?
In other words, so you have this long ST segment. Yeah, hypocalcemia.
The low calcium.
Yeah, very good. So if you see someone and they have a bunch of normal EKGs, and then you see this, check their calcium. Okay, where are we going
Fantastic.
next?
Abel, you got the last one right. So the board is yours. Impulse for 300.
Oh, this is a good one. The alternating PR intervals in this tracing can be best explained by what? What you see is you have a PR interval that's this, you see it here, and then you see this PR interval, which actually is the same. This is 140, this is 360, and so you have two distinct PR intervals. How might you explain that?
Anyone in the chat? Dual AV nodal physiology from
Yeah,
Dr.
excellent.
Tassi. Dual AV
Yeah,
node from
perfect.
EP.
Yeah, so you have a fast pathway and a slow pathway. Once in a while, you'll see conduction down the slow pathway and then conduction down the fast pathway. So you might be tempted to think this is some kind of block because it's irregular, but it's not. And the hallmark of this is you have two distinct PRs. And for whatever reason, occasionally it's going down the slow and at other times it's going down the fast. Excellent. Okay.
All right, Tassi, the board is yours. About 2 more seconds here. How about we do impulse control for 500?
What bedside maneuver was performed to elicit this change in conduction? It's not a drug.
Carotid sinus massage.
Yeah.
There we go by Abel.
Yeah, Abel, can you actually, I would like to hear you, if you don't mind unmuting and explain why you guessed that.
Let me give you permission here if you're able. Abel. Get it? That's for me.
Okay, hello.
Hey.
There is a dropped P wave that resulted from AV nodal conduction. So the vagal stimulation or the response from carotid sinus massage, the one like the one we saw earlier on the previous question, resulted in AV nodal block, resulting in a drop P wave.
Okay, I think that's close, and I may be not understanding fully, but I want to make this pretty clear because it's very important. Okay, so if you look at the left of the tracing, you have 2-to-1 AV block. If I were to march out these P waves march, okay? And so in the initial part of the tracing, you have 2-to-1 AV block. For every P wave, there's only one QRS, and then you have a block beat, then a QRS, and a block beat, okay? Now, if you have 2-to-1 conduction, you can't tell whether it's Wenke block or if for a Hessian block, right? You need a longer pattern in order to discern whether there's PR prolongation. So if you want to elicit whether the 2-to-1 block is due to infrahisian block or AV nodal block, you can do maneuvers with the patient. So let's just think about this. Now, one of the key things to recognize is the AV node is under the influence of parasympathetic and sympathetic activation. Okay, so and so is the sinus node. So if you do a carotid massage, you're going to increase vagal tone, your sinus rate will slow down, and your AV conduction could theoretically get worse. The His-Purkinje system is not under the influence of autonomics. Okay, so you can mash on the carotid all you want, but you're not going to influence His-Purkinje conduction. So if you're trying to determine whether this 2-to-1 block is infrahisian or AV nodal, if you massage the carotid, the sinus node rate should go down, which it does, and you have a paradoxical increase in conduction. Basically, because the sinus rate is slower, now the His-Purkinje system can conduct 1-to-1. Now let's consider the opposite, okay? Let's say this was AV nodal Wenke block. You are going to influence the sinus rate, but you're going to influence the AV nodal conduction probably more. So typically, if the block is at the level of the AV node, if you have 2-to-1 block, your AV nodal conduction should get worse. The opposite of this is also true. You could do exercise. If you exercise a patient, have them walk around, That increases sympathetic tone to the AV node. Your AV nodal conduction will get better. If you increase the attack rate by increasing the sinus rate to infranodal block, it'll get worse. So this is a very important concept, and you can see this like on the floor all the time. And I would encourage you, listen for bruits and all that stuff, but you can perform these bedside maneuvers that give you insight into the physiology of what's happening with the patient. Any questions about that?
I think that was great. Abel, the board is still yours if you'd like to guess. Don't die for 100.
This is actually one of my patients when I was practicing in Hawaii. This is a very famous rock that people jump off of, and on the North Shore of Oahu. So this guy, he's like a YouTuber, and his whole thing is he likes to belly flop off this rock. This is actually not that patient, but this is what it looks like when patients jump, okay? Now, this guy jumped, and he arrested. And the lifeguard saved his life, and the lifeguard actually happens to be my patient. So I asked him for the tracing. And so it was very rare, but I was able to get the tracing for what they saw when he was brought up to shore. So does anybody know what condition this is?
One of the guesses in the chat from Fifi was shiver artifact.
Nope, he was dead.
Chest wall trauma from Dr. Atassi.
This is actually something called Commotio cordis. It's extremely rare. You'll get very nasty polymorphic VT or VF. And it happens if you have, remember, if there's like blunt trauma to the chest and it's sufficiently high enough in terms of its impact, and it happens to be timed right on the vulnerable period of the QRS during repolarization, R on T, theoretically, you can have an RNT phenomenon, they go into VF. It's extremely rare. You often see it in children who are playing like baseball. There's some very interesting experiments trying to figure out if the size of this, object makes a difference, and it does, if it's spherical or not. But anyway, in this particular case, the guy jumped. That chest wall trauma caused an RNT phenomena, and he's very lucky that he survived. And he is still jumping off rocks. So would that be a lesson, I guess? Okay, but this is Commotio cordis.
I think that was what happened with Damar Hamlin from the Bills
exactly.
for our NFL fans.
Yep.
All right. So, Dr. Tassi, I think that chest wall trauma is, we're getting at the same point there. If you want to guess the next or pick the next question. And while we wait, it looks like it is pretty close. Oh, does he get an ICD was one of the questions from ERA. Well, Dr. Tassi decides on his question.
The short answer is no, he probably doesn't need one. He went to Stanford and got one. And so I probably would not have put an ICD in him, honestly. This is a little bit controversial, but in general, the experts in this condition will say it's just a random play of chance and you don't need an ICD. Good question.
You can break this up with a similar impact to the chest, can't you, as well? Like if you, like the pericardial thump.
Yeah, that's right. So we used to, back in the day, if someone were in VF, you could just like launch your fist onto their sternum. And if you timed it right, you could break the VT. It's been taken out of the guidelines now, but I've done it once and it worked. It was quite satisfying, but I broke a lot of ribs and, you could just shock the patient. So it's probably inadvisable to do that. But
Yeah,
same concept.
Yeah, exactly. So if you're in a similar situation, just throw them off the cliff back into the water again, and
yeah,
it should resolve.
I mean, I guess if you were in the field, you obviously rapid defibrillation is key, but if you don't have access to that, you could think about it. The problem is you don't really know what you're dealing with, right? So CPR is really what you need to do. Okay.
And I'm sure Parag's thoughts. Perfect. Let's do random facts for 400.
Random facts 400. First person to ablate, an accessory pathway using radio frequency ablation.
Anyone want to take a stab at this?
Anybody? Our faculty can weigh in. Gandhi, do you know? Okay, so the first person to do an ablation in human beings was Mel Scheinman. The first patient to ablate an accessory pathway was also Mel Scheinman, who was one of my mentored to a lot of people. But he used DC current, not radio frequency current. The first person, and really there were many people, but sort of the preeminent EP that taught us about how to ablate these pathways, he's sort of a wizard. He's also can be a little bit cranky, is Warren Jackman. And I'll just tell you a short anecdote because we're running out of time, but people thought he was crazy. People thought he was crazy because he was seeing things in tracings. He was seeing potentials that no one else could see, but he would get these pathways. So one day, Dr. Scheinman invited Dr. Jackman to come to UCSF where I was training because Dr. Scheinman was doing a very complex accessory pathway. Dr. Scheinman had tried twice and failed. So we brought Dr. Jackman in. We're all sitting there in the control room with Jackman, and it's very tense because he's an intense guy. Hours and hours and hours of mapping. He's just like, move here, move here, move here. After about 3.5 hours, he just yells out, screams, don't move, come on right here. And we came on with RF. It wasn't me, it was my co-fellow, and the pathway was gone. Now, we went back and looked at that potential, and none of us saw it. So he really is kind of a genius. And he really, I don't know, people thought he was crazy, but he was able to see things that other people just couldn't. And he taught us a lot about how to ablate these pathways. So props to him. All right.
How about why am I so fast for 200?
Why am I so fast for 200? Mm-hmm. Oh, this is a good one. What is this following tracing here? Okay, good. No brainer, right?
He says flutter.
Okay, so I want to teach you guys a little bit more here today. Abel, can you tell me, is this typical flutter or atypical flutter? Or let me ask the group, what constitutes typical flutter?
Hi. Yeah, so a typical flutter will have negative flutter waves in the inferior leads, that's 2-3 AVF, and then positive in lead V1. And
Okay.
this is a typical anti-clockwise.
Okay, that's almost perfect, but I want to make a very important distinction here, okay? Typical flutter means that all that means is that you're going around the tricuspid annulus, okay? So this is actually a case of mine. This is the right atrium, tricuspid annulus, left atrium, mitral annulus. When we say typical flutter in EP, what that means is that it's going around the tricuspid annulus. Now, you can go around the tricuspid annulus in a counterclockwise direction or a clockwise direction. So just because it's going counterclockwise, that has nothing to do with typical or atypical. What makes it typical is that it's going around the tricuspid annulus. Now, you very astutely pointed out that in typical counterclockwise flutter, that is the common, like, classic sawtooth where you're negative in 2, 3, and F and positive in V1. So the key is with typical flutter, you should always have, discordance between V1 and 2, 3, and F. Okay, now why is that? Well, let's look at this. You can see the wavefront here. You have to realize that the flutter wave is largely, this is what Waldo taught us. The flutter wave is largely the result of not right atrial activation, because most of the leads are actually on the left side. It's left atrial activation. And in order to get from right to left, there's only a few ways you can do that. You can go through the coronary sinus, which is right here. You can go through the fossa ovalis, which is here, or you can go through Bachman's bundle. Now, if you're going in the counterclockwise direction, look at what the first structure is that you encounter that allows you to get from left to right or right to left. It's the coronary sinus. The coronary sinus is a posterior and an inferior structure. That means you're going to be negative in 2, 3, and F because you're going away from the inferior portion of the atria, and you're going to be positive in V1 because you're going from posterior to anterior. Now, I don't think I have counterclockwise here, but just let's imagine if you're going clockwise, what's the first thing that you see? You'll see Bachman's bundle. The way you're getting from right atrium to left atrium is via Bachmann's bundle. The Bachmann's bundle inserts into the LA superior and anterior. So you'll be negative in V1 and positive in 2, 3, and F. Okay. So if you're discordant V1, 2, 3, and F, that's most likely typical flutter. And you can go further to say it's consistent with clockwise or counterclockwise. Everybody get that?
Fantastic.
Okay. Physiology is fun. All right. Where are we going next? Got a couple
Goofy,
more
it's
minutes.
all yours. All right. Well, about why am I so fast for 100? Nope.
Okay. This is a good one. What's the etiology of this rhythm here?
I don't see a pause before it.
Good. Was that you, AJ?
Yeah, that was me.
You get a gold star, man. I'm like weeping with tears of joy.
Anybody? Polymorphic VT.
It is polymorphic
from
VT.
PP?
It is not Torsade. What's going on? Look, you got to look at the whole tracing. So what do you see in this tracing on the left side? What's going on with the STs? This guy's having an inferior MI, right? So this is why people having MIs die. They don't die from pump failure. They die from electrical instability. Now imagine the poor EKG tech who's just hooking this guy up to the EKG and he codes, right? So we just happen to catch it. But this is an inferior MI leading to polymorphic VT. This is not Torsade. The appropriate treatment if you have a cath lab is to get them to cath lab. If not, you give them lytics, lidocaine if you want to stabilize them electrically, but open up the artery is key. Okay, so you can see this looks very much like twisting of the points. Polymorphic VT tends to look like twisting of the points. What makes it Torsade is pause dependency. Good. Okay, got a couple more here. Why don't we just go to why am I so fast for 500? What's the most appropriate treatment for this tracing shown below? Nurse wakes you up in the middle of the night. I'm really concerned. This patient had a really bad rhythm. Anybody? What's the first thing you want to do? Go into the room. The guy or the woman is reading the newspaper and talking to you. You have your answer. This is just artifact guide. Okay.
Yep.
So artifact can look really nasty. Now, a couple things. One, this is non-physiologic. You won't see things usually this fast. Two, if it's going this fast, the patient's going to feel it. They're not going to be just hemodynamically stable. Three, always look in multiple leads, because if you look down here, up here, you don't see it. But if you look down here, you can see these QRSs kind of marching through. See that? So this is sometimes called toothbrush tachycardia, because when people brush their teeth, they get this. That's artifact.
All right. How about device for 200?
Sorry, I just went to 100.
That's
what's the most plausible explanation here. What you see here is noise. This is an ICD with a single lead here. And what you see is like this very non-physiologic stuff. Again, it's like not real. The problem here is that the device doesn't know it's not real, so it shocks them, okay? And so this is what you typically will see with a lead fracture. And patients can be really miserable because they're getting shocked, but they're not getting shocked for appropriate reasons. So you got to turn therapies off because it's very traumatizing for the patient.
If you don't have the ability to program it, put a magnet over it.
Magnet, yeah. Okay. What kind of clinic is this patient most likely to have his pacemaker interrogated? Anybody?
A veterinary clinic?
Yeah, good. This is actually my colleague's dog who has a Medtronic pacemaker, I think. So this was obviously doesn't look very human. I don't know what the teaching point is there, except that dogs get pacemakers too. All right, random facts. First person to perform ablation, human being, male Scheinman. And random fact. Oh, former Abbott employee, played fullback, now CEO of a philanthropic organization. No one knows?
Oh, there we go.
Yeah. Have you do you still play rugby, AJ?
No, too many head injuries. I just watch it and sponsor it.
Okay,
But
well,
Six Nations is on, so. Well, fantastic. Thank you so much for that. That was a lot of fun, Dr. Singh, and I think everyone was really involved. So I appreciate everyone's participation. Just looking at the leaderboard, Fifi did take in the end with $2,300. We're actually going to pay out everyone on here, but I think we're doing it in Naira. So 2,300 Naira next time I see you, Fifi, and everyone else in the group. We'll make sure you're all compensated appropriately. But thank you all so much for joining. This was a fantastic lesson. David, do you have any final thoughts for us at all?
No, thanks for participating. I know over Zoom sometimes it's a little challenging, but I really appreciate everybody joining in. And feedback would be really helpful, as we kind of develop these curriculums. Is it too high level, not high level enough? Is it useful, not useful? That'd be great.
Fantastic. And, we're just starting this all over again. So there'll be more lessons that will build on each other as we go through the weeks. So we hope to see you in the following weeks. If you have specific, subjects that you want to cover, feel free to reach out to us and we can see if we can get an expert on that to present. And hope to see you all soon in person. All right. Enjoy the rest of your Sunday.